Okay, today we are going to talk about the underbelly in the entire healthcare system, especially here in the US, that is the electronic health record system. So, of course, you know what this EHR is. If you go to a big organization, it's going to be something like Epic or Cerner, maybe Meditech or CPSI, or any number of provider and physician level. There's about 500 different EHRs. The reason there are so many EHRs is that because basically, we bribed doctors to use EHRs as part of the Rescue Act in 2009, the high tech part of it. So that's when everybody who wanted to make a quick buck built software, put a lot of features on it, and then sold it usually to private equity. And that ultimately resulted in a whole bunch of software, 500 different vendors, some that are specialty oriented, some that are more generic, none of which have really been updated in the last 10 plus years. They're purely on maintenance mode. These are cash cows. These are entrenched players. Let's talk about what we might do differently using an AI first approach. Okay, let's get into it. This is what it feels like to be selling software into the healthcare industry. Me, I'm realizing I have to implement my software into an EHR written in Cobalt. This is not really a joke because actually a lot of EHRs fundamentally go all the way back to Cobalt in every version and micro version of technology since then, other than the most modern versions. And unfortunately, this means it is really painful as a vendor. Basically, you only exist as a vendor to offset a missing piece of functionality in the EHR. And then you have to implement inside that EHR with interconnected data because you're receiving data from one place and bringing it into another place. So, this is part of the problem. So, in the healthcare market in general, you have excessive costs. And everyone knows this who is seeing their high deductible premium go up. Meanwhile, their family's out of pocket 6 grand, the first 6 grand. No one can understand why things are so expensive. The bills don't make any sense. There's insufficient access, the ability for a patient to get the care they need when they need it and not delay and not overspend. That's challenging. It's a complex bureaucracy, whether you're talking about PPO networks of doctors or payment integrity firms behind the scene trying to recoup money that was already paid through sort of a late denial or fee schedules that ratchet but carve out certain services. This complex bureaucracy that's been built up is very challenging. And the legacy technology, the fact that there are EHRs written in Cobalt, and the fact that that's not abnormal, and that none of these tools are being updated, and everyone has their own self-interest. Everyone has a copy of the data, meaning your data is in more places than you ever thought. I recall a number that it was the average encounter, the copies of the data that's across 17 different copies of the data across the EHR, clearinghouse, various versions of the payer infrastructure, payment integrity firms, and so on. The entire US healthcare system is trapped in a dysfunctional, disorganized, profit driven web of bloated organizations and old technology. That's the world that everybody's been living in. All of the bolt on vendors that do get in the door and the EHR themselves, they are swimming in healthcare dollars. 1/3 of all healthcare spending is on administrative costs. And those administrative costs usually come in the form of labor and software. The fact here is that the software is driving more labor. So it's a sort of a snake eating its own tail kind of virtuous, non virtuous cycle. Let's talk about what this means from a US healthcare federal spending level. So this is Medicare plus Medicaid, fuzzy numbers, but proportionally correct here. Uh, Broken down by hospital admissions, emergency room, medication management, care coordination, and preventative care. Almost $2 trillion we're spending per year. And this has just gone up 5% or so every single year and is projected to continue to go up. The fact is that people won't take it anymore. It's, in my opinion, time to destroy every EHR. If the source of our problem is this octopus of software sucking out dollars and efficiency gains the place. And all the vendors can do is plug in their little add-on component until it looks like a barnacled ship going through the ocean with all these attachments and add-ons, where CTOs of hospitals have to hire IT folks that can manage each of these systems separately and how they interface. It's all very old school in so many ways, and it's way too damn expensive, as everyone in the industry knows. I'm proposing here the AI EHR, tomorrow's healthcare platform. Hopefully, folks are building this. I'm sure somebody is trying. These are my recommendations as to what we need, and I really don't think it's actually that complex. So, what I say when I mean EHR, I mean something that goes all the way from the time that a patient needs care to the time that they have paid their balance on it, and everything in between happening on this EHR. Okay, let's face it. I'm giving a presentation on blowing up the EHR industry when maybe everyone really just wants to hear about AI as spotting tumors better than cancer researchers might be on their own. I get that this is kind of a strange pitch to make, but the fact is that the EHR industry is at the heart of what's wrong with healthcare in the US and spreading around the world, because they're copying and pasting the same things everywhere. So when I talk about an AI EHR, I'm first talking about self-service family health. So this is the ability to monitor all of your medical conditions and your treatments and medication and doctors you're seeing and participating with, some of which are virtual, some might still be in person, that are all care coordinated for you. That's self-service family health. Next is an AI plus physician care management. So by the sort of the first level of all activity goes through the AI engine, so that for more self-service and recommendations of care plans, but physicians ultimately get to see everything that goes through the system, notate and jump in if needed. And then finally, insurance billing via the old claim system if needed, or even undercutting that entirely by paying for things as they happen, as well as self-service payment. So this is kind of the catch-all for current claims and remittance-based flow of data, as well as the more common self-service fee schedule that we're seeing more and more. And the goal is here to build from the ground up using AI tools to streamline the entire process. So, as a patient, you may have seen a situation where you wanted to see a doctor, maybe you even tried to schedule an appointment to see a doctor. By the time you actually saw the doctor, the majority of your symptoms and whatever it was had passed. In the rare case that it got worse, you're going to be wishing you had been in there sooner anyway. The reality is that even the logistics of accessing care are so painful and are so unpredictable, because if you walk through the front door in an emergency room, even if you have insurance, there's a reasonable chance that the doctors working in the EHR don't work for the same plan. You're technically out of network, but you have no choice, and you don't even know until you get $1,000 or $1,500 bill later for what ultimately ended up being a bloody nose. And I can speak here from my own experience. And this is something that's so frustrating. This has to do with the surprise billing, but it's so entrenched. There's so many different owners of resources all leveraged against each other. It's impossible to sort of make that all work. So from a patient portal view, this is patient-facing healthcare, not patient gets a fax or a PDF, a printout from the EHR. This is the patient-facing portion. So all of the medical history of the patient and their family, because this is always going to be treated at the family level. That's how support works and community works, whether it's, a daughter-in-law taking care of an aging parent, or it's a child, or it's a spouse. It doesn't matter. It's all about families. So the medical history of the family, and that includes every service rendered, plus every diagnosis and every treatment plan that you've been on, plus any genetic information submitted, and all the above. And this just builds over time and stays with the patient forever. A personalized care plan. So this is using that medical history plus sort of whatever acute thing or chronic thing is going on, and personalizing a care plan, and then proactively checking in with the patient patient. So you're never alone. So this sort of helps in a lot of ways. This for medication adherence, for example, for therapy at home, for any at-home service, really, you want an AI interaction to monitor the patient because you can't afford to have people show up at the door, and you don't want to have a big hospital building full of patients that could be at home. And then finally, claims and payment. So you'll easily be able to see what is being billed and what is being and payments that need to be made by the patient. One of the areas that I think is really interesting with this is from the insurance view, which we'll talk about in a little bit, but how to control spend, which is really where the money is when you're talking about sort of the federal plan level. The commercial plan, they make sort of a tax on every transaction, so they can make it work. But when you're capitated or doing a Medicare Advantage plan, those kinds of things, or Medicaid state trying to get better outcomes with a difficult population, this is important. Now, let's talk about physicians. The sign of what is sort of happened today with today's EHRs is that a physician will angrily joke, perhaps, me trying to comprehend why it takes longer to document my shift than to actually work it. This is what we have done. We have tried to take the interaction between the patient and the doctor and insert really bad EHR software in the middle of it, and that is resulting in a ton of missed opportunities to allow the human-to-human connection that you're supposed to be supporting. Instead, you have a human to machine, human by themselves interaction going on right now. And it has a lot to do not only with the software itself and the lack of ability to be more organic, but the stress that is put on a physician to have lengthy notes that can use to be supportive of perhaps a potential medical necessity appeal downstream. And so now I've got all these notes and these queries and a department looking at my documentation, and all this stuff leads to bloated communication. So let's talk about the physician-facing module. So first of all, they are doing virtual encounters. So whether this is synchronous, meaning the two people are on the meet at the same time, or asynchronous, meaning as a patient, you've already given me all the information I need. I can see some initial first round suggestions from the AI. I'm now recording a response back that will then be sent to you. You'll receive it. I may be working on the opposite side of the world. It doesn't matter. This way, there can be lots of me and we're all aware. The video of what I sent you and the content, everything is added back to your medical history and all integrated through sort of current large language model, graph database, vector database type stuff. Then from a second level, when you have a case that extends over time, chronic conditions, at-home recovery, all kinds of things like that, you're reviewing what had been going on between the patient and the AI of daily check-ins and mood and status and everything else. And you're adding notation, which will also be delivered back to the patient, or adjustments can be made to their caretaker, those kinds of things. And of course, if needed, you can intervene. So it's not on autopilot all the time. This is when you put the hands on the wheel and take control and redirect them, or do an instant intervention, whatever is needed for that moment. But of course, it's not about just being a doctor. As everyone who's gone through medical school really, really knows, there are tens of thousands of hours spent on clinical work, understanding disease, understanding treatment, understanding medications, the interaction between all these things together. And it can be really tough. And it has to get transcribed over to billing, including charge codes and modifiers, and one of tens of thousands of diagnosis codes. The clinical module is basically reference databases, all there in support of the overall treatment and care planning. The diagnosis database, so this is everything and every symptom, everything we know about various diagnoses that we're aggregating and referencing and annotating as needed inside of our own EHR here. The treatment database, so this is sort of clinical best practices, holistic approach, meaning it's not always interventionist. Some things play naturally over time. Sometimes in herbal over the counter is the best thing to use as opposed to a prescription that might be too strong. And then we're doing care planning. So a care plan database helps give context to the AI of what a care plan should be for a given diagnosis and treatment, and how to take into consideration individual progress, those kinds of things. In case you forgot, dead patients don't pay bills. That's a little dramatic to say that out loud, but the fact is, especially if you are in the world of Medicare, most of the spending in healthcare happens in the last months of life. The last 6 months of life account for like half of all healthcare spending in total. So think trillions of dollars in that last chunk of time. And what the difference is between a case being $500,000 versus being $50,000 has a lot to do with essentially a concierge-based approach. Right now, we just jam people into the highest cost of care settings and throw everything possible at them interventionally to create more revenue and also to try everything because that sounds like the right plan. We have care plan tracking. So what's going on in the care plan over an arc? If there are multiple chronic conditions and maybe treatment A wasn't working and now treatment B needs to be tried, and what's the outcome tracking of that? All of that is being organized by care plan tracking. A service scheduling. So this is basically setting appointments and booking services that may come to the home if it's a home-based care, or the patient may drive to a location where an appointment has been set up for them. Obviously, they could be Ubered there or whatever. And then escalation monitoring. So what's going on here from a concierge standpoint is if anything happens that needs urgent attention or needs rerouting, there is a human in the loop and assisted by an AI that can do various things that is helping make sure that everybody stays more or less on track and doesn't end up in their final resting place too early. Yeah. So right now in the EHR world, the moment that you realize your fate depends on handwritten visit notes, that's a real thing. And maybe there's not as many handwritten visit notes, but there are certainly visit notes. And those visit notes can be the difference between getting paid for services or not. And that's what makes this all so messy. All these tripwires that are part of this are part of this giant $2 trillion cost that the federal government is spending each year on providing healthcare through Medicare and Medicaid. If you were to implement this AI EHR, some rough estimates of what could be saved if it were paid for and implemented universally, meaning, let's say Medicare provided this free of charge to all citizens so that it can be free and used and not just sort of spotty, which is obviously, that's kind of a big stretch, but basically just to show the impact of cutting out cost. So from hospital admissions, saving $200 billion. From emergency room visits, saving basically saving 70% of the entire cost of ER visits could be saved here. Medication management, saving tens of billions of dollars across care coordination, everything else. Almost $500 billion is possible to be saved if we could implement an AI EHR that disintermediated a lot of this stuff. Now, let's face it. You might be just sitting there thinking, is that the future? It probably is, but does it matter because it is the way it is right now? And that's true. It is the way it is right now, and it's probably going to be a version of that until it's not. There will ultimately be a vendor out there that's providing solutions that probably do the majority of these things. We're probably within a couple of years of that happening. And the reality is that they are going to start wherever they can, as any good startup would, in providing a tool that maybe just costs $5 per encounter and it does all the things, something that's reasonably affordable at a per unit basis to afford cutting out all that cost. And the folks that are on the edge right now, the rural hospitals, the community hospitals, the physician-owned practices that are trying to keep it all together, family practice, all of these entities are going to find a way to use a next generation EHR that doesn't cause them more frustration and time spent in labor and denials and everything else. And as that grows, the insurance companies are going to realize that if they implement these tools, they can lower their medical cost ratios and they can spend less money caring for patients. This is especially true in Medicare Advantage, which are incentivized to either make you look sicker and therefore get more money sort of allocated to you per month. That's the scandal that's been happening now, or actually save money, which was the ultimate goal of Medicare Advantage anyway, by managing your care intelligently, keeping you in the loop, virtualizing whatever can be, keeping you out of the hospital. These strategies are unavoidable because of the track we're on. And so the AI powered version of the EHR is coming. And if you think your EHR is special, it's probably not. It's just a matter of time. So this is the AI EHR. I think we're going to see this in the next 2 to 3 years. I'm very excited for it because I've been one of those folks who's been on the outside looking in, and I don't think it's helping anybody. And at the end of the day, it's probably costing us so much more than we even realize, maybe even more than what I'm saying here. It's costing us the way we're doing things today. This is the AI EHR.